Good afternoon, everyone, to the first annual Tirone David Love Fest. It's almost like a Newport Jazz Festival or something. We've come to return to the Messiah. But the attentiveness and the size of the audience speaks volumes.
Thank you.
You didn't know you were so loved.
You're my friends, that's fine.
No, you've taught us so much. Now we're going to put you on the spot again. Tyrone will give us the first talk. State-of-the-art lecture for the afternoon, which is going to bridge the mitral and the aortic sides. Mitral valve repair and valve sparing route for syndromic patients.
The title was not my idea. The program was printed, Marnal showed me. I said, Marnal, we don't do that many. That's a rare operation. Anyhow, and she's my boss. I'll do whatever she tells me to do. Syndromic aortic root aneurysm is a different beast than we take care every day, the sporadic aneurysm. And I'm afraid one day in the distant future, certainly not in my lifetime, some of the younger ones, the manipulation of the genes is going to resolve this problem, not surgery. However, because they have a connective tissue disorder, the syndromic ones, frequently they have mitral valve myxoma degeneration. Actually, 80% of them do have myxoma degeneration. But if the valve doesn't leak, we leave them alone. There is enough information in the literature only about the Marfan syndrome, Lewis syndrome, and the sporadic. The sporadic is the one we do most of our cases. We have done some 700 aortic valve sparing, only 220 Marfan's or Lewis syndrome. The rest is the sporadic, non-familial. We don't know why they get, but they're still young. They're 30, 40, and 50, and present to you with an aortic root aneurysm. What's the incidence of concomitant mitral regurgitation that requires mitral valve intervention at the same time as the aortic root? Well, Dr. Gott collected 675 Marfan patients from 3 continents. Craig Miller's papers, Craig Miller patients were there included, Maria Kub, and they, in the 675, they had done mitral valve surgery in 12%. So they came for a root aneurysm, but besides the root aneurysm, they require mitral valve surgery as well. Hodgkin's experience, a single hospital now. Again, the late Vincent Gott published his landmark series of 271 bentals for Marfan's. The incidence of mitral valve regurgitation that required intervention is 15%. Ours, in 192 Marfan's patients, 17% require mitral valve intervention. And there's another multi-center trial of Marfan's, 16%. So you tell me, how often is this operation? Well, in syndromic, about 15%. So 1 patient in 6 is going to require something done to the mitral valve at the same time as the aortic root aneurysm. How about Lewis? Well, it's relatively rare. We talk a lot about, but there aren't very many patients out there. And Gouda has this collective paper, collected some almost 4,000 patients in the incidence of concomitant mitral regurgitation that required surgical attention was 7%. So it appears to be lower, but no single center has enough experience. Marnal and I have the impression it's a bit higher because in our hand we have done 22 Lewis, and 8 of them require mitral valve repair at the same time. So how often is this operation that Marnal asked me to describe it to you? Valve sparing combined to mitral valve repair. It's not often at all. It's not very common. That's why I don't think it would be appropriate to be discussing here. Cleveland Clinic is a very large institution. Only 43 patients out of 118 who had the combined operation of Marfan syndrome. In Toronto, 54 patients had combined operation and 28 MRFN, 3 Louis syndrome. And Jabrin and the group from Laurent from Brussels published recently, they had 45 patients. So the majority of patients who require aortic root surgery combined to mitral valve are not syndromic. Syndromic or not, the issue is, do you do both operations at the same time? We do. We do because it's a long operation, and that's one of the things that I asked Pedro Daunido to come and talk to you about myocardial protection. These are long operations. Look at the cross-clumping time, 160 minutes. If you clamp an aorta for 160 minutes, you better keep the heart alive. Doesn't matter how beautiful your repair is. If the heart is dead, it's a waste of an operation. I don't know why the pacemaker rate is higher. I guess a dacron graft in aortic root, a ring below, it must cause distortion of the central fibrous skeleton of the heart, and the membranous septum must be distorted. But the pacemaker rate is much higher than in all the series. Survival is excellent, yeah, but they're very young. They're 40, 50-year-old. And in our hands, there's a higher reoperation rate in both, if you do combine. Likely because I'm in a hurry. You don't want to extend the cross-clamp beyond 160 minutes, so you try to shortcut, and we are paying attention to this now. Do not compromise. If it takes an extra hour, so be it, but do the best possible operation. That's why I sound like a broken record. Unless you keep examining your outcomes, you don't become a better surgeon. And we are learning this by looking inside. Look what I have done. I cannot blame anybody else because I have done all 56. So if I had the heart block, that's my fault. Do something to prevent them. We start to cannulate the patient, and we always look at the aortic root first. Can you darken the room a bit more? It'll be all video from now on. And take the sinuses out, leave 3-4 millimeter of sinus attached to the annulus. We already inspect the aortic valve and decided to protect the heart. In these patients, I do not use the needle. The long cross clamp, we cannulate both coronary arteries, tie the coronary cannulus to the aortic wall, and let the perfusionists protect the heart. Our policy is 500 cc's of blood with some potassium, and that's how we protect the heart. And then, of course, we go for the mitral valve repair first. This patient has a flail P3 and part of P2. I don't do anything else but use Gore-Tex, pass a Gore-Tex, tie the papillary muscle, and then 2 or 3 knots there, take the longer arm, and you start bringing to the free margin the leaflet. What I have learned in the past 40 years since we introduced Gore-Tex is that more Gore-Tex better for the patient. Every millimeter or 2 of free margin, particularly anterior leaflet, you should put 1 corda. So keep a bund of Gore-Tex as opposed to be fewer and take a chance. Single passage in the fibrous portion, 2 passages in the free margin of the leaflet. So the commissure is flail, is prolapsing. So instead to close the commissure, which where is Dave Adam? You can say, close the commissure, I'm wasting our time with Gore-Tex. Yeah, we can do that as well. And I cannot make an argument against. If it's too long operation, perhaps closing the commissure a bit more, do Carpentier magic stitch, the imbricated one, would be the same. I like Gore-Tex. I think it works very well, and I use Gore-Tex galore. My average patient gets 14 new cordas. When I use Gore-Tex, I use resection too. And simply all the same thing. Pass twice in the leaflet, pass once to the fibrous portion of the papillary muscle, and tie the Gore-Tex on the papillary muscle, so the knot is inside the ventricle. This patient got maybe, I don't know, 16, 18 new corda, because it was quite an extensive area of prolapse. So you start a new one again, keep going until you find a normal cord on the other side. I promise that you stay within 20 minutes. I timed this video properly and not to be abuse of your time. And I'm a very conservative surgeon, so I don't resect the cord that can be used to protect the Gore-Tex. I even imbricate the Gore-Tex in the... So the papillary muscle is certainly very crowded with Gore-Tex in the fibrous portion. But remember, the tension in each one is minuscule. You should not rupture. I've never seen rupture papillary muscle, to be quite honest, in this operation. And then when the prolapse is fixed, with consecutive loops of Gore-Tex, we tie the ends together, and this fixes the prolapse of the A2 and the A3. There's a small little false commissure in the anterior leaf. We close that stuff with a 5-O-proline. But first, fix the prolapse. So that's a normal chorda now, but we end the Gore-Tex in the normal chorda, so we know precisely the length. Actually, that's how we calculate the length. Starts with a normal one, goes to the abnormal, and then a normal one. So you know how long to make the Gore-Tex chorda. And then, of course, all these patients need a annuloplasty. And I, to be quite honest, in the past 20, 25 years, I use only posterior band. I don't know why I'm giving these patients a higher incidence of heart block than the patients who have either isolated mitral valve repair or isolated aortic valve sparing. Aortic valve sparing is very rare that you have. We try to clump the proximal part of the aorta to see if there's any residual prolapse, and it looks pretty good in a water test. Water test doesn't mean there'll be no MR afterwards. It means there's no prolapse left. That's what you're measuring. And then go back to the aortic valve. This part of the operation is crucial. You have to dissect the aortic root below the aortic annular junction. Certain parts you cannot dissect. This here you can't. If you try to go below the aortic ventricular junction there, you're going to open the right ventricle. So leave the attachment to the right ventricle there and put a suture through the right ventricular wall. Then I'll talk tomorrow a bit more about this, but the aortic root is cylinder. Anybody who knows anatomy knows that. The aortic valve evolves through a cylinder, not through a sphere. That's why I have never, and I will never, use a Valsalva graft. It makes no sense. It's irrational. Francis Rubisek is the one that came up with this idea. He came to me in 1995. That's what I should be using. I said, no. Make me one that has a cylinder with 3 bulges, and of course I'll use it, but not a sphere graft. Tomorrow I'll talk more about this. This suture line is very important. I don't use any pledget along the muscle. I had 2 or 3 holes in the anterior leaflet, and since then, the pledget suture along the mitral valve has a pledget. We cannot buy soft pledgets, so we make our own. In other words, here's go to the lateral fibrous trigon, well below the junction, at least 2 or 3 millimeters below. We put a pledge now, and then bring the graft down. The degree of scalloping of the first suture line is crucial for this operation. If you cannot make a perfect horizontal suture line, say in one area like now, in the membranous septum, I go a bit higher to avoid the bundle, you have to go higher in the graft. How much higher? Or the same height that you create in the outflow tract. 4 millimeters higher, put 4 millimeters higher in the graft. Jabrin is very good in this. He measures everything. He really is almost like valve sparing for dummies. You measure everything, put a bunch of markers, and anybody can do the way Jabrin described. You should go and watch him to do this. And then, of course, when you tie the suture line, you are fixing the annulus. This annulus never dilate again. There are 10, 12 sutures all around. I do not believe you get away with only 2 or 3. Has to be a truly annuloplasty. It's not hemostatic. This is only to secure the subcommissure triangles. This is crucial again, but anybody who uses stentless valve or homograft know how to do it. Look at the same direction that black mark came in, put the commissure right on it. And the upper part I secured a pledget. Soft pledget, felt pledget. And then once all three are suspended, you inspect the valve. More often than not, I have to realign one commissure to one side and the other. And you want to make it as much this way. Look, this is prolapsing. But the prolapse is likely because the cusp was too elongated, not because I put a graft too small. The smaller put the graft, the more prolapse you're going to have. Bigger the graft, less prolapse, but may not coapt properly. And then everyone changes this technique. When I travel, you're a visitor, keep our mouth shut. But if they ask him, I tell them, that's how it should be done. You take one bite from outside in through the annulus, and then inside out to the upper part of the remnant of the aortic sinuses. Not running suture. This is too delicate a structure to run from inside a casual. Nature is very unkind to us. If you do a sloppy suture line, there'll be remodeling of your suture line. There'll be scarring. It's going to change and come back to haunt you. A year later, there's moderate AI. 2 years later, reoperate on the patient. There's no secret here. We have to put the coronary artery as high and away to the left side as possible, as close to the left side as possible. And then, of course, reimplanted the left main, which is a bit simpler, very seldom kinks or there's any problem. And finally, now is the key. You have to, I shortened the non-coronary cusp already, and the right cusp has been shortened as well. You want the cusp to coapt all the same level. Jochen Schaefer's has a caliper. I don't know how to use it. I think we have at home, but I never used it in my life. You take a forceps, a suction, and see where the cusp is lying. We have eyes, for Christ's sake. Take a look inside. You'll know if the cusp is too high or too low. It doesn't take a genius to, my scribe nurse knows if it's too high or too low. Actually, I have a scribe nurse to me next to my side. She can judge prolapse or not. And then, of course, do the upper anastomosis, and the operation is done. Long operation, very seldom under 3 hours. And the question is, well, if it's a long operation, is it reproducible? I think it is a good operation. Marau published recently, we had the 56 cases done. Patient survival is excellent, but remember, they're 40-year-old, they're very young people, they don't die. But look at the reoperation rate. At 10%, 11% had required either mitral or aortic. Sloppy surgery. We don't have this high reoperation rates for either isolated AVR, isolated valve sparing, or isolated mitral valve repair. Reoperations in the mitral valve is much lower, 4.2, in both of them 11%. In 9.2 develop moderate or severe AI at 10 years, and 4.5% develop moderate or severe MR. These results are not as good as either one in isolation. Again, to my broken record, that's why you have to keep examining results. Since Marau published this paper was published the year, but ended the analysis last year, we changed our tune. We are taking much more care of either part of the operation. The mitral valve repair, dealing like any mitral valve repair, no hurry. There's no point in shortcuts, and the same for the valve sparing. Thank you.